His name is Dr. Dan Beilin. He holds a doctorate in Oriental Medicine as well as a master's in neurophysiology. I think that, boy, neurophysiology, that's the secret to medicine and dentistry as far as I'm concerned. In the past 11 years, Dr. Beilin has studied in Germany, Austria, and Switzerland with notable biological physicians such as Thomas Rau, Hans Nieper, Maria Blecker, and Helmut Schimmel. 2.5 years ago, Dr. Beilin began a study of infrared and contact thermography. His teachers are the most notable clinicians in this new and cutting-edge field. Dr. Beilin discovered the most meaningful and comprehensive system, and he'll now discuss its ramifications in defining focal fields in dentistry and medicine, and actually how to prioritize where to start on any given patient. He makes a comment given to him by Dr. Rao. He says that with every single patient, I begin to understand their global situation by the thermographic system of IABDM. Is that how you pronounce your company, IABDM? IABDM. So without further ado, I introduce Dr. Dan Beilin.
Thank you, Chris. Yeah. No, that's fine. That's great. Thank you, Chris. Does this reach? Maybe we can detach it. Yeah. I'm the first pure overhead lecturer. Did everyone get one of these? We're informed that only 10 people did not get one of these, and it has about 10 pages behind it. So then see Tim Larkin, who's in the back of the room. Would you stand up, Tim? And he'll give you this after the lecture and the break time. So some of you know me from Darkfield. I still do that. It's impossible to replace Darkfield by anything, so of course do Darkfield still. And I think the three most valuable instruments for any holistic practice are, now I feel in this order, thermography, Darkfield, and BTA. So if you want to go out and get all three and have the ultimate clinic, it costs somewhere around $35,000 for all three. So you can do that over a course of maybe a couple of months or something. That's a joke. Right now in Germany, there are approximately 1,500 thermographs that are being used. There are some in hospitals now, in radiology departments of a couple of hospitals. And dentists use them, about 200, 250 dentists in Germany, Switzerland, and Austria. Dr. Rost was a medical doctor and dentist also, and so he studied different ways to try to get to this autonomic nervous system that we all are trying to get a close understanding to. He found that by taking the measurement of the actual skin temperature, which is called contact thermography, it bears a closer relationship to pathology than what you've heard, maybe read about in the alternative medicine journal, the infrared systems. The infrared systems are dealing with the radiation that comes from the skin, and therefore they've established that the pathology is not as clearly defined. So this is what we see in the journals in Germany now, and it's coming here to the United States as we get it through the FDA in another couple of weeks, we're informed. This is a little bit of a summary about what it is for your assistants. It's a good idea if you have a woman assistant, because what happens is that it's possible to do it in a little bit different way, but the normal way is for the person to take off everything from the waist up and be exposed to cool air for a period of 10 minutes. And you take this test before and after that 10-minute period. So you're looking at the relationship of the first reading to the second reading taken 10 minutes later. And you're seeing how the body responds in various regions, which are ramifications of the projections of the autonomic nervous system to the skin from the deeper organ. So here we say, what is regulation thermography? We call it regulation because it's a dynamic form of thermography, whereas before and in the other systems, the method was by just taking a snapshot. And everybody knows that if you just take a lab test one point in time, it not necessarily tells you much about the active dynamic physiology of the patient. So this is a dynamic system, which means that it's sort of like the dark field in that it tells you, it's a direct, real-time image of the autonomic nervous system. So we see it's a measurement of heat of the body, so it's done by a probe that's placed on different points, about 90 points of the body. So we can get a good insight into the focal areas of diseases. And the regulation thermogram, is, I'll show you in a little bit later, we'll show you some patients whereby we were able to identify a focal disturbance field in the mouth or in other organs, and then determine whether that's the key focal disturbance field or not by taking then a third reading and seeing the body regulate. So according to Dr. Ross, not only the temperature but also the regulation of the temperature follows physiological laws and is dependent upon the vegetative regulative ability of the associated organ. Therefore, examination of thermal regulation is suited to measure and evaluate the ability to regulate of the whole organism as well as single organisms. That's the neat thing about regulation thermography is you see a bird's eye view and then you go into a specific organ or a specific tooth area. And so there's 8 points in each quadrant of the teeth, and there's even points for the exocrine pancreas as well as the endocrine pancreas, the head and the tail of the pancreas, which gives us specificity that we've never seen before. If you take old systems like the SEG, which is a comparable attempt to analyze the autonomic nervous system, the SEG system is like seeing very far away with blurry glasses and sort of making out, well, we see somewhere in the right lower quadrant that there seems to be the crux of the problem. With the regulation thermography, we see exactly that it's, say, the splenic flexure. So here we have a dental thermogram. And this happens in every thermogram. You get all three. If you don't want all three, you can also tell the computer, I only want the dental. You still have to take off the clothes of the patient from the waist up. On women, I have done it for obvious reasons with the bra on, and it still seems to work. So in a dental clinic, I would have, if you're the sole practitioner and there's no physician on board, then I think for liability purposes, it's just a good idea to have a woman do the work. And it's very easy to train someone. We have videos now, and we help with the training. So it's very easy to show them the points. The points are neurological points. They're not acupuncture points, but they're very simple and easy to learn. So that you get a dental program, a body program, and of course a breast program, because we know if you read in the literature now, it looks like different types of thermographic techniques are going to replace mammography. Dr. Bloom is the leading teacher of thermography in Germany. She just came out with a new book, and she's studied thermography for about 20 years. She practices in an area, a beautiful area, resort area called the Tegernsee, which is a lake area southeast of Munich. She's discovered by taking statistics of discovering breast cancer that a higher percentage of breast cancers are caught with thermography than mammography if you use any one of these alone. So if you use just clinical palpation and clinical diagnosis, and add thermography, there's approximately a 15% increase in the diagnosis of dysregulation, and then by surgery, definitive tumor identification, 15% better than radiology alone, than mammography alone. If you add them both together, you get 98%, which is unheard of in normal mammography, as you know. So what we want to see what it looks like to have a normal thermogram. First of all, I'm going to tell you a little bit more about measuring the patient. The patient has to be a little bit relaxed during the appointment. They shouldn't do any activities that can cause an artificial artifact to appear. They should adapt themselves to the room temperature. The room temperature is just a little bit cooler than this, which is a normal clinic. Some doctors say, well, I'm going to build a special room and we're going to freeze the room and make it into the thermographic room. It's not necessary at all. It's just about 67 to 70 degrees is fine, because that little amount of exposure to the cool air is enough to initiate a regulative response. And that's all we need. We need to see how the body the skin will go back to the nervous system, to the spinal cord, and the connections to the organs and back out onto the skin will provide a very clear picture. So the patient sits for a few minutes, and then they should be stopped off medication for, I believe, about 24 hours, unless you want to see how they are on a medication. Like if they're taking thyroid, you can keep them on that. And then they shouldn't have regulative therapy beforehand by a couple of days. And this means some type of neural therapy or something that's going to change the situation. So what we do is we see these different ways to look at the reaction of the body to the cool air, and it's all in the computer diagram that we're going to show that's output with every patient. Dr. Rao told me, he says, well, it took me a little bit of some time to learn to interpret these thermographs. Do I really want to add this to the clinic, is what he was afraid that a lot of doctors would ask. Well, he was using the old thermographic system that only gives you a chart readout, and it's not the new program. Now he's just recently bought the new program, and he can say now that it's very simple to teach the doctor. There's 4 or 5 doctors that fax me all the time, and that's the way that they learn, so that immediately I write in my comments, just knowing a little bit about their clinical situation. And just by doing that with the fax service, then it's very accommodating, and it's a very good relationship built up, and you're able to learn it in about a month. So here we have the different areas that we're able to define. And that's just a bird's eye view. It's not going into the precise area like maxillary sinus on the right side. We're able to get that specific. So here we have the head, the neck. The head contains the sinuses, the brain, and the teeth. The neck contains the lymph and the thyroid. The chest contains the bronchi, pulmonary system, and cardiac. The upper abdomen contains the pancreas, liver, stomach. Lower abdomen is large intestine, and pelvic organs, and the back contains the kidney and vertebral column, as well as the 4 quadrants of the mouth and the breast. So why would anyone want to do thermograph? And it's sort of like the electrocardiogram of the whole body, in that it interfaces with the body in a way that we're all looking for. We're all looking for something that's objective and something that's going to measure subtle biological problems, because we don't want to be like normal allopaths where we wait until the person is so sick and all their laboratory reports are way off normal, because that's in many cases too late. We see the prognosis of chronic diseases. we see an ability to locate the exact orders of areas of disorder. We see a comprehensive diagnosis of the focus of the disease. We see non-subjectivity, and although I believe in subjective testing like kinesiology and these type of things, I come from a background that's mostly scientific, so I like to have some pure science and know that if a scientist or an authority came and said, well, what's the basis of this, then I could say, well, it's purely physiological. And by the way, in dentistry, I have the bibliography of thermography. The bibliography of thermography as of 1987 has approximately 400 articles just on dental thermography. So dental thermography has been used for a long time. Now there's probably 1,500 articles on dental thermography. So it's been known to be a working system to help us to diagnose. And I think what you'll find more and more is that there's going to be more and more dental apparatuses that will come up with a thermographic analysis of what's happening to the teeth. And you can see, do you need to start with the teeth really, or should you handle some organ somewhere else, refer them to your naturopath or acupuncturist or holistic medical doctor, and then have them refer you back when they've taken off sort of like the outer peels of the onion. And so then you can do the deeper work and relieve the focus in the mouth. By the way, almost every cancer patient has at least one focus in the mouth. Would the dentists here agree with that?
Yes.
And I've had my best results with cancer patients when I get the dental problem handled. It's just astounding. Last year I had a multiple myeloma totally normalize, and she's doing fine. And the doctors at Sloan Kettering could have sworn that she would not live more than 6 months based upon a tooth focus. I had 2 breast cancer patients. One I sent to Dr. Rao in his dental ward. They did an extraction. She's cancer-free by UC San Francisco Department of Oncology. So this is it's a relevant field for tumor diseases. In other words, what we see in tumor diseases is dysregulation in particular areas and an overall what's called a chaotic thermogram. And when you see 2 or 3 of these signs, you know that the whole body is set up for a cancer. And if the person does not have cancer yet, then they're lined up for it. You can treat them, do a thermograph 2 weeks later or 1 month later, and you can see the change. So what we want to do is make it impossible for these things to live, and the way to make it impossible for these tumor creatures to live is you create an environment that has regulation in it. It's like we want to, Dr. Rao puts it in a very Germanic way. You line up your troops in a good way, and that's regulation to fight the disease. I'm not so sure that fighting is a great word. I think the Enderleinian way of making it so that these things do not have an ability to advance, so you create a milieu that doesn't allow it to advance, I think is a more creative way to talk about it. Here we see Dr. Bloom, who's on the Tegernsee. She's writing articles and books, and what we're going to do in the next 6 months is bring her over, and so we're going to have a little first symposium on regulation thermography. I'm sure all of you have seen these kind of somatotopic or head zone charts. All of you who have studied some amount of neurology have gone through these kind of charts, and they're mostly disregarded except by neurologists, and that's really wrong. All medical doctors should be very much aware of this. So we see this connection. Here is a little picture of the probe that's used that touches the skin, and it beeps twice very quickly, and it takes 30 samples per second, and it's accurate to 0.01 degrees Celsius. And you see I'm drew in this little redness here. This is really a color thing. And you can see it going to the afferents that go into the spinal cord that are also connecting to the organ over here. I just took a piece of intestine and scanned it there just to represent an organ. And its interlink at the spinal cord to the nervous system, and then going back out and showing that it affects the capillary beds of the skin. Now, from the neck down, our bodies, when they're exposed to coolness, constrict capillary-wise, so we get colder on the skin if we're subjected to a cool temperature. And from the neck up, we get warmer because the head is trying to push all of the blood to itself in a stressful situation. So what we see on the thermogram is this. So here we see the head. Here we see the neck and the chest, and you can see that here is the first reading and second reading of each of these areas of the head. You see the first one is actually a black line, the second one is a red line, and they're rising over that 10-minute period. So we go through doing the test. The whole test takes 20 minutes. 20 minutes, you're done with a printout. Your assistant can hand it to you while you've been doing other things. And Dr. Elmahian is constructing such a clinic whereby he has delegated. I also in my clinic have that delegated, and so they just hand me a result so I can be seeing a patient at the same time. So here we have in the head region everything rises, and here we have in the neck area, except of course the thyroid, for obvious endocrine response reasons, a little bit of a rise. So this is called the ideal thermogram, or what we all would like to see in every area. And what we have here is first of all, the forehead is the first point taken, and they've discovered that if you go into the desert or if you go to the Arctic Circle, this point is the most consistent temperature regulated point of the entire body. This point will not change. So if you take measurements right here, then that's a consistent baseline, and that forms this baseline of the entire thermogram. So that's the first point. The second point is the nasal route that shows us some reflection of the blood pressure, which has a lot to do with the autonomic nervous system also. And then we have the elbow creases on both sides that show us a very good indication of whether there's a focus on the right side or the left side, or if there's a focus at all. So you can have something funny in the dental thermogram, and you can confirm it by looking at the elbow creases, because what they've discovered is the elbow creases are the furthest away from the center regulative system of the body. The elbow creases are, since they're the furthest away, they're like a feeler that you have. Say if you had a wire going over to that window, that would be moving the most if there's something wrong at the center. And so that's a very sensitive marking system. And that's the same thing that they have shown here. When this second reading does not come down like it should, like it does here, but instead it stays the same, then that's rigidity, and that's suspicion of a focus. And the confirming way that we have is to look over at the end of the thermogram, which is also the elbow crease, and if it has the same rigidity or unchanging in between the first and the second, the body hasn't been stimulated there for some reason, right? There's a block, and this is the right and the left side. So we can have a good idea. Let's look in the rest of the thermogram for the right side problem, and often you find it in the tonsil or the teeth, and the right side or the left side, whatever side you find, will correspond to the actual pure rigidity that's found in a focus. So if I have a focus in the right tonsil, then you'll see it over here in the elbow crease, and then you'll see it in the tonsil. And everywhere else, it won't be rigid. So it's very clear in how it shows us. There's just these simple little things that you learn along the way. So just maybe put this in your mind about how a normal thermogram looks. You see that you have a sine wave in the teeth. You see that the back teeth, here's the back teeth, and then the front teeth, and then the back teeth create a sine wave above and below the baseline. That's how we want it. From the neck down, everything's below the baseline. And in the breast, everything regulates downward. A hot spot above here is a suspicion for a focal problem there. So as your dentist, I'm just showing you the points on the teeth that are measured. So there's this side and then the other side, so there's 32 points. And if you look at what this looks like in a dental diagram, these are the points and where they're measuring. So on the skin, they found that these are exact corresponding points to the roots of the teeth and the areas around the roots of the teeth that are projected onto these somatotopic zones of the skin. So this is, again, what happens. You have the patient is at rest, then you do the head measurements, then after you're done with head measurements, the clothing is removed from the waist up, and then you complete the first measurement, and you wait a period of approximately 10 minutes. At 10 minutes, the temperature stops changing. So the body has completed its adjustment after this 10-minute period. This is the result of 20 to 25 years of work and thousands of patients. So it might seem a little bit new, like there's a little bit of a question. When you see what work has been done and the references that have been done, and then you go to clinics where they're using this, and you see clinically what they're identifying and how they work with this, that's what I've been doing for the last 2.5 years. I've gone for about 6 or 7 sessions of lessons in thermography with the individual doctors at their clinics. See the second measurement, and of course you don't have to rush on that second measurement. And then what you can do is look around and see, this looks like a probable focus, say, in a wisdom tooth. We can take Procaine Notikel, or however you do your neurotherapy. You can inject it, wait 5 minutes, and do a third test, and see that now it's not rigid anymore, and you might have had an organ being influenced by that rigidity in the mouth. That clears too. So you can see, if you inject a focus, you can measure it immediately on a third test on the thermography. So in another 10 minutes, right, 5 minutes you wait for the effect, 5 minutes to do the test again to get a third test. You can see in the first one it was at a certain level, the second one it didn't change, so that's blocked, so that's a suspicion. And then you do neural therapy and immediately you do a third test, and now it regulates. We unblocked it. And we have confirmation that it was that exact place that we were addressing. So this is a definitive way to find the focus and make sure that it's the one that's influencing the rest of the body. So that's what's so neat about the method. So here's a real thermogram, and this is a patient this is a multiple myeloma patient. And you see here in the dental thermogram the loss of that sine wave, especially here in the upper quadrant. You see that it's in the front, it's way below. And also there's a loss of the below baseline aspect here in the lower jaw. Now there's a really neat little thing they have here called a fan diagram. The fan diagram is a very precise location of where the most stressed quadrants are in the mouth. Here it says 7 and 10. That's at about 12:30 or 1 o'clock. Anything above 12 o'clock, and that's very clear to use this fan diagram, area 7 and 10. So we know that there's a problem in the right upper or the left lower. Well, if we look at the right upper, here we see that there's hardly any change in this tooth right here, which would be about the first molar. And pardon me for my lack of knowledge of tooth numbering, but I'm not a dentist, so I would just send the patient to the dentist and say, please do a panorama of the left or the right upper quadrant. And of course, then we all have the problem, well, it has to be somebody who can do the reading of the x-rays, which only the people in this room seem to be able to really know how to do. So here we have a little bit of a rigidity here, and then we have these great falls. You see how big that fell down? Can everybody see that? And you see that some parts of this are blocked. You see how this did not change in the sinuses? This is the maxillary sinus, and it didn't change here. So here you have a block. Here you have them coming way down, and here you have them coming above the baseline. Remember what the ideal thermogram looked like? It was below. But look at how hot this person is in the lymph. Well, it turned out that she had a history during 15 years of her childhood of chronic tonsil infections that never resolved completely. But she also had a tooth focus. She was supposed to die a year and a half ago, and she's better than she's ever been. We did this by addressing the tooth area, and we identified an area on this upper right. I think it was here in this rigidity, and that was removed, and appropriate therapy to the tonsil, actually to this area of the lymph here that's blocked here. And she's doing fine, and the doctors don't understand this, and her husband doesn't understand, but he's so excited that he has his wife back again. She was on the deathbed 2.5 years ago after chemotherapy failed. So here we have, you see how this is coming down over here in the lower abdomen, but it's also going up. This is called chaos. When you see chaos, you see a cancerous condition that could happen. And here's the different types of thermograms that you look at from a sort of a bird's eye view. You see, this one is not regulating enough. A lot of these are rigid here and here. You see these little rigid areas, and you look at the whole thing. It didn't look like it comes down like the healthy thermogram did. It didn't come down below the baseline here. It's sort of blocked, so that's called hyporegulating. It's not really able to initiate its true healthy reaction. Here we see hyperregulating, where it's initiating too much of a reaction, almost like some parts of the thermogram we just looked at in the mouth. That means a toxicity in the area. This means tendency to, that there's proving of a focus and a long time enzymatic block. And here in the bottom we have the chaotic thermogram, which most closely resembles what we just saw, and this is most typical of a cancer patient. So a person cannot, it can be possible they come in very often and they don't have anything diagnosed, but this would bring about great suspicion if they had one like this, because look how this is blocked, but this is hyper-regulating, but this is hypo-regulating, but the whole thing is not coming down below the baseline, but we're getting this mix, and a crazy mix is called chaos. So another way to look at that is, here's part of the lessons. Here's the 4 ways that you can see a reaction. So here is before the cooling and after the cooling. And these are the same. You can see that those are the same. It doesn't matter that much. It really matters what happens to that particular area after they're subjected to the cool air. So here's healthy regulation. Here's an inflammation. See, this is inflammation, probably infection. And here we have the hyperregulation, where it's a toxic allergic, they call it. It can also mean an overtherapy. If some of you dentists or doctors want to know if your patients have taken too many supplements and they've been over-treated, and the autonomic nervous system is always trying to compensate for having too high concentrations of unnecessary substances, and they're having to excrete this, and it's overburdening, they get a hyperregulation. And then hyporegulation is, of course, the worst, because that's the block that we have to find out where the focus is, and that's what is the most important thing now about what we're discussing. So by this technique, we have this kind of a way to analyze, and this is sort of like how my mind works, and with the different areas. So here we have the organs at the top: gallbladder, pancreas, liver, stomach. And we look here and you say there's a block here in the gallbladder. And we look here and we say that the intestines are hot, they're way above the baseline. And we see here that the intestinal point, actually the second point comes up, so there's an inflammation there. And there are certain signs that they've learned to interpret. One of them is, like, you can see fungus in the GI tract by a certain sign. Another one, you can see the food intolerances. You can show gluten reactions, you can show carbohydrate problems. And so we have a system by which we can analyze the thermogram by looking at 3 factors in these seemingly complex pictures like this. But actually they're not as complex as they look. Well, we remember how we talked about chaos, how you don't want chaos. You want to line up your armies or line up the biology so that it reacts correctly. Well, we have a chaos index that's called CI. So a CI is the amount of chaos there is. Well, we don't want chaos, so we want a low number there. And here's the first test. So that's how they're resting. That's in their resting state. And you see that a lot of these are in the 4s, and that's a little bit high, but we don't worry about that. What we want to look at is how the body reacts to the stress. So we want a dynamic way to look. If we do many other techniques, I'm not going to mention them, but that are subjective, a lot of them are just taking snapshots of how the body is, but they don't really stress the body and then look at how they react to the stress. That's more important. So what this does is, in the CIB, it looks at how the body reacted. And this is a 1 to 6 scale, and so we want them to go down. So here it went from a 4.5 on the first reading, and the second reading, in all the red marks that you see, the second reading, 3.8, it went down. Here we see 2.7 in the lymph system. That's area 2 is the lymph, area 1 is the head. So 2.7, it went down to 0.4. So that's great in the lymph. And then here we have 1.8. It went up in the heart area, or the bronchial area. Here in area 4, it went up in the liver pancreas area. But look at this one. Here in area 5, it went way up to 5.6. Area 5 is the lower abdomen. And what do we see right here? You see in the right, left ovarian area, an infection here, or possibly a cyst, and in the uterine area, the first point's right on the line, and the second point is again in an inflammatory state. And then we see a little bit of a rigidity here in the ascending colon, and that's all. So we know definitively that so far we have a problem in the left ovarian system. The kidneys are fine. You see this nice regulation in the kidneys. You see that, according to the elbow crease, that there's nothing blocked, that they're both regulating downward. Here you see an inflammation on the left side, though. Look at this. This is very interesting. On the left side, at first, you see inflammatory regulation, which could be a reflection of this left ovary. You see blocked lymph. Remember what the rigid thermogram or the hyporegulating thermogram looked like? This lymph sort of looks like that. So now we're going to look at the teeth. And let me tell you about something new. There's something new that just came out 2 months ago in the software, and that's called the indices of the new computerized analysis. What they did was they got all of the information from Dr. Rost, and he had dental information for 30 years. They have another dentist that they work with. They got a psychiatrist who has a hospital near Lake Constance to see whether all of his patients had certain patterns that were psychiatric disease-based, to show if the psyche, if there's a way to see how much the psyche influences the body. So we have an actual psychosomatic or somatopsychic index. If it's high, I send them and mention that there could be something that would be open in their mind to go into a psychotherapeutic mode or whatever their method is. And so we have this psychosomatic index. These are all 1 to 6, 6 being the worst. Now, after Dr. Rost, he was very good with diagnostics of precancer states. This tumor terrain, which I'm not sure that name is going to be changed just for liability's sake. The tumor terrain, if this were at 4 or above, then that would be high potential for a tumor to be there. And then Dr. Rutenberg is another guy that's been working for about 15 years on this. He made this metastatic index. It's the tendency for the body to actually accept a metastases. So if both of these are high, it's very bad. And then a new index done by a gastroenterologist that uses thermography for 8 years, an enteropathic index, which means the degree to which the gut is creating the problem. So as you may or may not think, if you take the sinuses, the tonsils, and the teeth, and the gut, you have solutions to most medical problems on this planet. So the gut is extremely important. Most sinusitis this is my opinion and from what I know and from my lessons and my teachers, most sinusitis are not totally resolvable until the gut is dealt with. And then here we have the teeth. So in German, teeth is Zahn, Z-A-H-N. So this is the teeth index, and we see a right half and a left half. You see that the left is up to a 3.6, which is significant, and we can actually forget about the right half. So if you have something to define this very clearly, then you're one step ahead of everybody else in trying to look to see, well, is that amalgam really bothering that person on the right side? And you could say, let's let that go for right now, and let's look at the left side. And there are many other ways in this to look and see where it is. But let's just look at that left side. So here we have the sine curve. That's what we're looking for in dentistry, and it's pretty much there. But we have these rigidities on the left side, and not quite as much rigidity on the right side. So here we have that's showing here, and also here you see no rigidity here. Everything changed. Do you see that? From the black to the red, everything changed. But here, look at this, rigidity here, rigidity here, rigidity here. So there's a suspicion of either areas 8 or 10. What we do is we go into this bar diagram. For the teeth, we can see the 4 quadrants here. The 7 is upper right, upper left, lower right, lower left. And we see this area, see this color? That's the rigidity. That's the degree to which a focus may occur. And there's a 38% rigidity in that lower left quadrant, which was the suspicious area where you saw this block. this reaction index, this RI, shows if there's an inflammation or a degeneration. Anything above 3 is inflammation. And we see here 3.8, and all the others are below 3. So we know to look exactly in that quadrant in the lower left. So here you can have a choice anytime for these kind of fan diagrams, which give you the priority of organs that need to be looked at. And then you have the same thing for the dental quadrants. And then you have this pie diagram for the breast. Now the pie diagram can't be as big as this, because that means that the right breast is much different in temperature than the left breast. And when you have that eccentricity of the two sides, then we know that there must be a problem. And we see here, they give you these gray areas to know what's normal, and a behavior in the breast of a little bit of inflammation and block. But here you see a real big problem, because none of these areas of the breast are coming down to the normal amount, and they're definitely not matching this right. So we have a suspicion of a big-time dysregulation in the left breast. Sure enough, this is a breast cancer patient before she had a lumpectomy, and then I sent her to Dr. Rao in Switzerland. You can see the chaoticness of this thermogram, although it's not horrible like that representation, but you see there are areas that are losing their regulation, both in the abdomen and in the lymph, which is exactly what you suspect in breast cancer, is that you see there are hot zones in the ovary and pelvic area, there's chaos in the abdomen, and then the lymph is blocked. And you can see on this right tonsil, it's almost completely blocked, and in some of the other lymph, in the cervical lymph.
What does it show the stomach there?
The stomach is here, and of course the stomach is very much connected to the breast, and many times you can see that in thermography, the stomach connection with the breast, but it's not here. It's in normal regulation here. But what you also see in breast is the pancreas points being hot and a little bit rigid, and whenever you see pancreas points being hot, then there's definite linkage to the urogenital system. And when you see urogenital, this is also representing hormone endocrine balance imbalance. And so that would project back into the breast. So you just have to learn these little pathways of the urogenital to the breast connection and the pancreas points, and then sometimes the stomach. Usually what happens with the stomach is it comes down very far in mycosis. So if we're going to know, we want to use Pefrikel, do we want to use L-glutamine, do we want to use Fortikel, do we want to use Acidophilus bifidus, the stomach point will come down very far, showing that kind of mycosis. So here we have again the ideal thermogram, just to give you back into your mind what it looks like. And you can see that in the head it's above and everywhere else it's below. And remember, the breasts should be the same, and they should be long like this, and the teeth should have this sine wave. This is just meant to give you a reminder. And here we have the fan diagrams. You should see this, which is 1 o'clock and 2 o'clock. We have 4 different areas of the body, but we don't have anything in the teeth here. And when I see patients like this, I know that we can wait a little bit on doing any dentistry. We can work on the body, and then we can see if the dentistry comes out. But at this point, it's not crucial to go to tend to the problems in the mouth. And that's different than this situation, where we see the overall dysregulation here, which is a G, which is the general dentistry. And look at the dental. Look at this. Now look at the rest of the thermogram. Look how healthy they are here. Everything is pretty much perfect. And look how we get up to the lymph, up to the head. And we have these blocked areas in the sinuses. And then we look down here, it's completely blocked in the dentistry. This is the type of patient that if you send them to the acupuncturist, send them to the naturopath, the patient will never get better. Here we have, you can see this pink number, that's rigidity. So that's rigidity in the body. There's not really very much. And actually, in the lymph, you have 85% healthy and 86% healthy in the chest and 43% in the pancreas, liver, and 73% in the urogenital. And kidneys, though, have a 75% hyporegulation. That's dangerous. So if you want to give the patient something while you send them to the dentist, you can give them kidney drainage. So here we have fixed 38%. And then we have a chaos index that went up from 0.7 to 2.9. So this is very suspicious here. Everywhere else, the only other place it went up is a 2.7 to a 3.0. That's not very significant. Also, you have a 63% normal. So we have actually the area 7, which is the right upper quadrant. And you can look at the right upper quadrant and see here that there is rigidity here towards the front of the mouth. And so that's where I would start. So actually you're getting this down to 3 teeth in the right upper. And of course, look at this number 4 in the body. So we just want to look at that because we need to have 2 or 3 definitive factors in the thermogram to tell us, okay, go, you have to work on this particular organ. And so the fan diagram is only one definitive factor. We look at area 4. Is anything abnormal? Yes. It went up from a 2.2 to a 4.3. You see that 4.3? It's the biggest amount of chaos of the whole body. And we look down at area 4, normal pancreas, normal gallbladder, normal liver, a little bit rigid, and here the stomach is rigid. So we have stomach, and then around cuspid, bicuspid of the upper right. So we treat this patient with whatever you use for his stomach. I use enzymes and Chinese herbs and minerals. Here, yes?
If you do, say you wanted to try this patient on your supplements, could you put them on the body and see if it's changing?
No, it's not an energetic test technique, but I tell you what I do. I have patients that fly out from New York or the East Coast or far away, and I say, come for 2 days. And when they first get there on, say, a Monday, at 10 o'clock they come in, we do a thermogram immediately, and then we see immediately what are the most stressed organs. If it's not the teeth, then we can treat the body, and we can give them quadruple dose of things overnight. So if I give them, say, thymus, I give them 4 T-cell formulas 4 times a day. I give them a very high dose, and the next day we can test them at exactly the same time with no interference, making sure they don't eat and things like that. And you can see the change overnight to know whether you're going in the right direction. So that's a quick way to assess. The other way is by doing some neural therapy in that suspicious area, and then you can do a test 5 minutes later, because the neural therapy, of course, has to be done repeatedly in most cases, and its effects kind of might wear off in 24 hours. It might be hard to do neural therapy and then see an immediate result the next day, but you can see that result for that temporary period of time for a few hours. Yeah?
Seeing changes after just homeopathy, rapid quickly. Like the rapid variable heart rate monitor that Core Oil uses, that sort see those rapid changes in the
Yeah,
autonomic nervous system.
yeah, if you get the right remedy. The right remedy is, I'm sure all of us would be homeopaths if we were as good as, I don't know, there's, who are the new Israeli guys that are teaching now. They're where Sankaran got most of his information. How many here have read Sankaran, Rajan Sankaran? If you want the sort of like the latest philosophy of homeopathy and how medicine works. How many people know Herring's law here? His 3 laws of cure. So you know that Herring was a homeopath in the turn of the century, and he came up with these laws to know whether your patient's getting better. So one is that the symptoms go from above downward. So they had a headache yesterday and now they have a stomachache. Another is from the reverse order from which it came. So when they were a kid, they had a bad sore throat, and then they got asthma for the rest of their lives, and the sore throat is gone. You treat them with the right remedy, and they get the sore throat again, their asthma clears. And then from the most vital organ out to a lesser vital organ. So if they have an asthma, you treat it, and they get a dermatitis. And then they go to the doctor and get cortisone, and the asthma comes back, and the dermatitis is cured. This is Herring's law, and Herring understood the direction of cure. And so if you want the latest Herring, it's portrayed in Sankaran's book. One's called The Spirit of Homeopathy. Another one's called The Substance of Homeopathy, because every health practitioner should know homeopathic philosophy, because it's the philosophy that's the deepest of healing. And everybody knows, where did homeopathy come from? Where did Hahnemann get his ideas? Anyone can shout that out? Huh? Socrates. Oh, Hippocrates. Paracelsus.
Paracelsus went back to
Yeah. What? Okay. Sankaran? Sankaran. A-N. Sankaran. His first name is Rajan. He's Indian. He's Irish, yeah. So I think it's essential that we all know that Paracelsus really wrote the Bible on understanding how diseases progress and how to make them go away, because he knew the true secrets, and the true secrets are, of course, protected by nature. So, that gets into our alchemy and the future of what's going to happen here, is you're going to see more and more spagyric medicines come out, which are going to be acting like the strongest plant medicine, but without toxicity. So we're going to have echinacea that's going to work about 1,000 times stronger than it works now, with no toxicity. And that's going to be in the next 5 to 10 years. Already there's patents on, and there's a pharmaceutical company that's starting to make them in Switzerland. So I just want to show you a little bit about, look at this breast. So these are the areas of the breast. You see this A, B, C, D. So here's the lateral upper A, B, C, D, and then another A, B, C, D, and then the nipple point. And this is a woman who had a breast tumor here in this area. And she wanted to know whether she should have the tumor removed. And I sent her to UC San Francisco and told her who the surgeon should be to properly do this. And so she had the surgery. Look at her thermogram. Is there anything normal here? There's no sine wave. There's no below the baseline regulation that you can barely see this gray area where it should be. Look at all the blocked areas. So even though she's 27 years old and she has She has a very poor prognosis because everything is hot. You see that there's a big block in the left ovarian and in the uterine area. Then we just do the best we can and send her for the surgery. And after the surgery, you can also see that in the opposite breast, there's an autonomic reflex of showing the exact same points that are in disarray. You know that in women below the age of 40, if they have a lumpectomy and they have radiation to that area, there's a 60% chance of recurrence in the opposite breast in young women. And this is why, because the autonomic regulation crosses over and plugs into the exact point on the opposite side. So here we are in your biological clinic, and you want to take a nice history, of course, and you have to consider and look at the dentistry. This is sort of how I think in my clinic, and you as dentists can do here history, dentistry with a global consideration instead, so you'd have these reversed. And then we add the thermography and we get the prioritization of the organs versus the teeth. It might be a good thing to have dark field also, because that has a whole other level. And then if we have a serious degenerative problem in the body, that's when I would call on the BTA, because the redox potential of the blood is so close to very severe degenerative problems. And then we do a prioritization based on the regulatory influences in the terrain. And then if we get therapy failure, we see what we did wrong with the CRT. With the thermography, we can see what we did wrong. And we as doctors should look all the time about the things that we do wrong, because we do so many things wrong, right? Hopefully not, but we learn as time goes on with our patients because everybody's so different. So if you didn't get one of these with an article in back of it, Tim has, I think, 10 or 12 more copies. And please make sure if you come to the booth of thermography that you sign our mailing list, because we're going to always just send you different things, tapes and things like that. So you want to at least be on the mailing list for getting our subscription to our new newsletter that we're trying to come up with and things like this. Okay, so I thank you very much. Thank you, Dr. Hussar.
Runs down from the breast, from the root canal down to the breast.
Could you put that last slide up for another minute, please?
Don't forget, at the end of the conference, we'll have a panel discussion, so you can save all your questions for whoever is giving their lectures, okay?
I get to introduce myself today. Our next speaker is both dentist and physician. Charming, witty, sometimes arrogant, great sense of humor. Sometimes your ass. I'm going to talk to you about hyperbaric medicine, which is a relatively new subject for me. I've been playing with it for over a year, and I'm a little slow to respond to things. I've known about it for probably 10 years. And with the grace of my wife and another doctor that got us into this, we've been able to help a lot of patients with it. My lecture isn't as great as my usual one on Nico lesions, but most of you have heard that. I don't want to put you to sleep. So I'm just going to give you a basic rundown, about a 45-minute course on hyperbaric medicine. And I have just some things to read and some slides to go over with you. And I'm trying to apply it. There isn't much dental there isn't a lot of dental material here other than osteoradionecrosis, which would be patients who have been radiated because of oral cancers, for example. But you'll get the gist of how this works, and there is some applications to what we're talking about. But since this today seems to be geared at a lot of medicine, that this is important for other diseases too, which you should be cognizant of. In your handout, that blue book that you got when you came in, there a little 3-page article that I wrote, and there's 13 accepted diagnoses for the use of hyperbarics. In other words, if you had a hospital clinic or you were going to bill Medicaid or Medicare, they will recognize these diseases as being diseases can be treated by hyperbaric medicine. Hyperbaric medicine, as you probably are aware or unaware of, is basically oxygen under pressure. Patients sit in a special chamber, either a monoplace chamber, and they are pressurized up to 3 atmospheres of pure oxygen, and they breathe oxygen in this closed container, or they will sit in a pressurized chamber that's pressurized with compressed air and breathe oxygen through a mask. A monoplace chamber means one person gets into it. There are dual place and there are multi-place chambers. These tend to be in large hospitals or naval settings, for example, all right? The 13 approved diseases include decompression illness, gas and air embolism, carbon monoxide and cyanide poisoning, gas gangrene, selected aerobic and anaerobic soft tissue infections, osteomyelitis, especially of the chronic refractory type, sternal wound infections, such as the type someone would get after a CABG surgery, a coronary bypass. They get chronic sternal osteomyelitis, radiation injury to tissue, pelvic radiation necrosis and radiation cystitis, which we're seeing a lot more of that nowadays, now that prostatic carcinoma is on the increase and men are being radiated. Blood loss anemia, crush injuries and other traumatic peripheral ischemias, skin grafts and flaps, adjunctive hyperbaric oxygen and treatment of fungal disease, and the enhancement of healing in selected problematic wounds and thermal burns. There are some innovators out there, like most of you are, who have experimented with hyperbaric oxygen for other things. In particular, we have seen a lot of Lyme's patients, being that we're next to California. I'm from Reno, Nevada. We have a lot of patients from California where Lyme's is epidemic. You all know what Lyme's disease is. It's mostly caused by a spirochete, a tick bite. A lot of people that I'm seeing, and you're probably seeing in your offices, are chronic fatigued, or they have weird neuralgias or neuropathy secondary from chronic infections from this little tick that carries a spirochete. It has been shown that it may benefit patients with silicone toxicity, even patients who have had breast implants that have leaked, for example. Chronic fatigue syndrome. There's a nurse in Maryland, Baltimore, her name is Aiello, I believe, who has set up her own clinic. And they try to kill her 3 times because she is basically curing AIDS patients, or at least keeping them alive with hyperbaric oxygen along with nutritional programs. And she's keeping the virus at bay with hyperbaric oxygen. We have seen some benefits in multiple sclerosis. Some of the newest innovations include treatment of brown recluse spider bites, which is rampant in the West Coast here, severe head injuries, closed head injuries. There's an article I just came out using it for acute MIs, myocardial infarctions, and I think that the future of hyperbaric medicine will be in stroke patients, patients who have either had chronic strokes or acute strokes. Steve, you're here. Dr. Schaub was a patient of ours. We treated him. Steve had a cerebral vascular accident, as did Ed, and we put both of them in our chamber. You feel like saying a few words about that? You know, you came into the office and you had a cane, and when you left, you were playing bridge, I think, weren't you? And he went from a Democrat to Republican. No. Oxygen, as you know, is an antibiotic, okay? And it impairs bacterial metabolism. And oxygen displays a broad range of coverages for multiple organisms, in particular anaerobes, which is what you're going to find in the jaws. The hypoxia, which accompanies ischemia and chronic infections, inhibits the immune system. Hyperbaric oxygen corrects that. Hyperbaric oxygen enhances phagocytosis by inducing free radical production, and it's cidal to most organisms. In fact, some HBO has been is directly bactericidal and bacteriostatic, and equivalent to many types of some cephalosporins by itself.
How about the flesh-eating bacteria? Tried that?
Yes, it's been soft tissue infections, the Clostridium type. You know, the
These are not Clostridium.
myofasciitis.
Myofasciitis
Right.
is bacterial, not Clostridium.
It's very useful in that, right? Most of it's strep and staph, but it can be Clostridium. I've seen several cases of that. Horrible disease. But this is, because there's no circulation and the infection travels so fast in the fascial planes, this is where this helps. But you also need to do antibiotics, and you need to fillet them, basically. But this certainly will help them. ozone, hydrogen peroxide. Unfortunately, most hospitals don't do that, but personal experience with myself and my clinic with hyperbaric oxygen has demonstrated that exposing cavitational patients to hyperbaric oxygen prior to surgery for at least 1 or 2 sessions produces a wound that bleeds appropriately and they heal faster. The better they bleed, and Dr. Nye said this yesterday at lunch, that the more they bleed, the faster they heal. So if you get a little ecchymosis, that's fine. That means that they're going to heal up better. That's great. That's what I look for, okay? Osteomyelitis in particular produces hypoxic conditions in the tissue. Intramedullary oxygen pressure tension measurements have revealed pressures below 30 milligrams or 30 millimeters of mercury. However richly blessed the tissues of the jaw are with vascularity, this can become quite easily compromised due to the nature of the end organ circulation and the infections that arise. Hyperbaric oxygen specifically raises the oxygen tension in ischemic hypoxic tissues. Oxygen-dependent mechanisms employed by the body to kill bacteria are enhanced by hyperbaric oxygen. In particular, these mechanisms include hydrogen peroxide and superoxide production. One thing that it does do that's great for surgery is it enhances osteogenesis, which is a problem with all of us as far as the healing goes. And the better osteogenesis that you can get, the faster your wound is going to heal. It also produces neovascularization. So any tissue that is compromised by blood flow, you will enhance the healing by increasing blood flow to these areas. That's the simplicity of this. It's, Mother Nature's tool at its best. And it's just so great. It's not invasive. It's simple to do. Basically, patients get into the chamber for at least 60 minutes at a time. Sometimes we've treated patients up to 2 to 3 hours. The chronic Lyme disease, sometimes we'll stay in for 2 to 3 hours. We've gone as high as 3 atmospheres. We are here at an atmospheric pressure of 1. If you get into the chamber at 2 ATAs, means you're pressurized an extra atmosphere, so you have 2 atmospheres on you, okay? And basically, 2 atmospheres equivalent to approximately 33 feet underwater. That's what that means. So when you dive a patient, you're taking him down to that pressure as being underwater. Let me show you some slides. Yes. Yeah, a lot of times we've had one case of barrel trauma where the eardrum actually perforated while she was being pressurized. That's why you have your technician or whoever's running the chamber right there, and you say, how are your ears doing, how are your ears doing, as you pressurize them, as you take them down. What we do sometimes prophylactically is I'll examine the patients and see what the tympanic membrane looks like. Oftentimes they'll have tonsillar pathology and eustachian tube dysfunction. So that's when I inject the tonsils with the neural therapy as we do, and then I take my finger and try to manipulate those with an old osteopathic technique and try to loosen up that area. And sometimes we'll do a little, just some generic nasal spray, like neosynephrine, to open them up, and that's usually all it takes. There's one compound that I use from Stu Russell's compound PHP called mucolytic drainage formula, which opens up things dramatically. So I use several different things, but that's usually what I do to treat that. But that's one of the worst things that can happen is barrel trauma, which is relatively simple. The ear, nose, and throat sees them, and usually it puts a patch on it or a heal up. We examine the patient first, and you say, have you had any ear problems? Have you had ear infections? Look at see if there's any fluid, things like that. Okay? I need something to work like right now, because like they're going to the chamber in 5 minutes or 10 minutes, and there's a schedule. And you're right, euphorbium works great for me. Can we kill some of those lights, please? Don't shoot them. These are some slides I got from the Underwater Medical Association, and so I cheated a little bit. I had to make these myself. So we're going to talk about refractory osteomyelitis. There was some allusion to osteomyelitis being in infants. Actually, it's quite common. It usually appears in the long bones of the body, as most of you physicians know. By the way, when you do your billing, patients have recurrent pain in the jaw, you can use this code, chronic refractory osteomyelitis, because that's basically what you have is chronic osteomyelitis that has been around for such a long time, and sometimes refractory to our treatments. But the insurance company looks at that. But get a biopsy. Not for chronic refractory osteomyelitis. I just use, I think, 526.4 or ischemic osteonecrosis 733.4.
Like
Yes.
I did one this last week, and I could not get anything to biopsy. It was just like nothing.
Was the bone real hard and sclerotic?
Well, I went through the cortical plate, and there was just a big hole.
Oh, okay. Nothing
in there.
Yeah. Well, how about the mush?
I
You
watched
get-
stuff in there, but I didn't, it was too thin, too fluid, I couldn't grab anything.
You know what you can do when you do that?
What?
And I'll divert here. Take a syringe, have a syringe ready by your surgical table, like maybe an 18 gauge or a 20 gauge syringe, and as soon as you open it up, just suck it up into the syringe.
And that's my biopsy?
Yep.
Thank you.
And send it to Boco, and send a little bit to your lab just for culture. If you have a patient that's kind of difficult, you want to get a culture and sensitivity. And while we're on that subject, there's one antibiotic that has killed every bug that I've cultured so far, and I use it usually orally, and you probably, if you're into antibiotics, Cipro, C-I-P-R-O, and I usually put patients on that a day before surgery. I give them 500 milligrams twice a day, and I just get in there, hit them hard and fast, and get out, 5-day coverage. So I give them 10 tablets, and they start the day before surgery, and they're done in 4 or 5 days. Okay? And it usually works. Cipro. Yes?
What was that lab you said for biopsy?
Dr. Boco, Head and Neck Diagnostics in West Virginia. Dr. Boco is the expert he's the oral pathologist that's done more research on these cavitations than anybody else in the world, okay? And he's coined the term NICO, which we're not going to use, right? Between us, we can use NICO, but that's a buzzword for the insurance companies. So they're chronic refractory osteomyelitis, they're ischemic osteonecrosis, okay? Use the medical terms, the scientific terms. If you call his number, I don't have the 800 number, Carol probably has it. There's an 800 number, and you talk to Dr. Boco, Jerry Boco. Talk to Dr. Boco and say, you were at the American Academy this weekend. Will you send me some of his materials? He's written 10, 11, 12 articles on NICO lesions, and have him send you some biopsy containers. Get used to taking biopsies. B-O-U-Q-U-O-T. Jerry Boco. He has lectured here before several times. Anything else? Can you kill this light over here, please? A little right in front of me. I think it's the top switch on the left as you look. Right above that. No? Okay. Then there's different stages of osteomyelitis. I'm going to buzz through a lot of these. Different signs. There's medullary osteomyelitis, superficial, localized. We're going to deal with alveolar, of course. We've talked about this several times, and we alluded to this morning with Vaughn's statement about you have 3 different stages. You have physiological stages of normal host, then you have a host that has a systemic compromise, which is going to be most of your patients, or local compromise. Systemic compromise might be someone who has cancer or chronic fungal dysbiosis, chronic candidiasis, where there's another drain on their autonomics and their immune system someplace else. Heavy metal toxicity would be another example of that. And then you have a host where the treatment is going to be worse than the disease. And these are your patients that are, for example, heavy smokers and patients. The worst combination would be a heavy smoker and somebody who's been on steroids, for example, someone who had Crohn's disease. And I made this mistake. I worked on someone who had both, a young lady, and she had a couple root canals to take out because of atypical facial pain. I said, you're a poor surgical candidate. I really don't want to work on you. She says, I don't care. I'll take the risks. And we operated on her, and I got a horrific RSD phenomena, which I'm not sure if she's out of it yet. She left my office, and I haven't heard from her. I'm waiting to hear from her attorney, one of those deals, you know. So please choose your patients wisely. Somebody that has a smoking problem and an RSD or an alcohol problem or something like that, or something that would make them ischemic, malnutrition, work on them first, or defer them to somebody else. You don't need that aggravation, and not to me. Here's some clinical trials of chronic osteomyelitis, bacterial in nature, 2 ATAs, and when there was 2 atmospheres of pressure for 2 hours for 10 to 40 treatments, 5 cases of chronic osteomyelitis, all responded to hyperbaric oxygen with surgery and no antibiotics. Here's a couple more cases here, 3 to 45 treatments at 2 ATAs for 2 hours, 24 patients with chronic osteomyelitis. The sinus, that's not this sinus, that means there was a draining sinus from the leg. 17 of those healed up. Those with sinuses, 17% or 17 of them healed up. 4 relapsed. Some sinus discharge left, and 3 had no effect. All had surgery. Some had antibiotics. 5 patients with chronic infections, pseudoarthrosis. This means they had a fracture somewhere, and it was set, and it never healed up, so they never got a complete union, a bony union of a joint, and it became infected. These 5 patients had 18 to 32 treatments. All responded to hyperbaric oxygen, and some had antibiotics. Basically, a real graphic depiction here of what you're doing. Hyperbaric oxygen, oxygen under pressure. This is the host, this is the bone, and this is the bugs. And that's basically where all the interface occurs. This is where the action occurs. Another example of patients with chronic non-hematogenic osteomyelitis. 38 patients with proven osteomyelitis, which was unresponsive to conventional therapy, which means surgery and antibiotics. Treatment included local debridement again and parenteral antibiotics and hyperbaric oxygen. Patients received culture-specific antibiotics and an average of 48 hyperbaric treatments, which was quite highly coordinated with medical and surgical care. 34 of the 38 became disease-free for an average of 34 months, whereas only 4 of the 38 had been free of any signs or symptoms for 3 months during the 24 months prior to initiation of hyperbaric oxygen. 30 of those 34 remained disease-free for 7.5 to 10.5 years afterwards. This is a woman who had a prosthesis put in. This is a bone scan of her leg. I'm sorry, she broke her leg, broke her hip. They put a prosthesis in. She developed fever and chills several days later. This is the bone scan. This is the femur. This is after 10 hyperbaric treatments where you see increased vascularity. After 20 treatments, her symptoms were abated. There was no more fever, no more pain, but there was more activity on the bone scan, but this represents new vascularity, neovascularization. So basically, she was treated with hyperbaric oxygen with nothing else after the prosthesis was put in. That was only 20 treatments, by the way. This is another patient who was a bulldozer operator that his bulldozer went over a cliff and it basically crushed both lower extremities, the femur and the fibula and tib. And this is before and after pictures of hyperbaric oxygen. I think this is approximately 10 treatments. Obviously no vascularity here. This is a computerized bone scan, and this is after 10 treatments. These are the lower right hip and femur. These are the lower extremities. This is the hip and femur. This is prior to hyperbarics. This is after. This is 10 treatments. Notice the increased vascularity. He went on to be 11 years after. He was followed for 11 years. He had no more symptomatology, no more signs of osteomyelitis, just after hyperbarics and after his legs were set. Here's a young kid that had a pitchfork injury to his knee. The knee became infected, but after several cultures, they could never find anything. So he was tried on different series of antibiotics, both IV and oral. Nothing seemed to work. This is September of '73. These are the segmental white blood cells and the lymphs. Usually in somebody 11 to 12 years of age, these are pretty much equal. But look at the disparity here. And this is in December, after approximately 20 hyperbaric treatments, that his blood hemogram has become somewhat more normalized, with an increase in lymphs and a decrease in segmented neutrophils. That's just from hyperbarics. This is after antibiotics. Same child or same individual, hematocrit hemoglobin. He even had several transfusions in the course of his treatment. The hemogram somewhat stabilized after hyperbaric oxygen. Albumin actually went up. Globulin went down. And total protein went up. This is albumin. This is protein with hyperbarics. I don't know if some of you are familiar. There's been some articles showing Alzheimer's patients have albumin levels that drop. So this might be a treatment source of Alzheimer's along with other things. Even the sedimentation rate dropped dramatically just using hyperbaric oxygen. Osteoradionecrosis. This is patients who have had cancer of the head and neck area who have been radiated, and this is one of the great instruments, the hyperbarics, for the treatment of this disease. The effects of radiation: tissue cell death, sclerosis of the vasculature, and aseptic bone necrosis. What does this sound like to all of us? Alan? So maybe we're all taking too many x-rays and we haven't even looked at that as a source of, disease to our patients. Now when I say radiation, I'm sorry, this means therapeutic oncological radiation, right? But the things are very similar. Tissue becomes hypoxic, hypovascular, and hypocellular. When you get your biopsy samples back from Dr. Bocco, he says very few osteoblasts, very few osteocytes, no bone cells, no white blood cells, very avascular. With patients who have had under 2,000 rads, this is just a measure of radiation dosage. For those who are not familiar with this. Usually no problem in most patients. They heal up anywhere between 2,000 and 5,000 rads. Possible problem. Anybody who receives over 5,000 rads, you better anticipate a problem. Well, it sounds like what we do, doesn't it? Radiation affecting tissue continues to worsen with time. It's cumulative.
There's no safe radiation.
Right. There is an oral surgeon, for your information, if you're interested in following some of this. His name is Bob Marks. He's at the University of Miami, who has done most of this research. So if you're interested in pursuing some of this, I encourage you to look up some of his material. Radionecrosis regimen is usually 90 to 120 minutes at 2 to 2.4 atmospheres once daily. The tissue PO2 raises to 81% plus or minus 5% of normal after 18 to 30 hyperbaric oxygen treatments. Always consider preoperative HBO before attempting surgery in a significantly radiated field. If you have a patient that you think is compromised, and it doesn't have to be from radiation, we talked about other patients before, like I said, they will heal better if you can get them into a chamber for maybe 1 or 2 treatments and then possibly follow them up with 2 or 3 treatments afterwards. You'll notice tremendous healing increases. 30 HBO treatments usually are given before surgical procedures other than simple extractions. This is for patients who have been radiated. The lasting effects of hyperbaric treatment may permit repeat surgery for up to 2 years without additional HBO. Soft tissue radionecrosis. HBO treatment of soft tissue radionecrosis at Duke. From these years, 75 to 90, 86 patients, 8 to 100 treatments, an average of 39 were given. 2.5% deteriorated, 7% stayed the same, 76 improved, and 12 were resolved completely. Protocol for removing teeth in an irradiated field. You take them to 20 preoperative dives first. After surgery, you do 10 postoperative dives. And you may need more than that. Teeth are removed without reflecting the mucoperiosteum. Yeah, fat chance for me. Perioperative antibiotics are used, 92% success rate, okay? So you have to be real careful on these patients. That's why it's important to diagnose cancer when it's early. That's the guy's name, Bob Marks. Dead bone must be resected. There's nothing that you're going to do to regenerate bone, at least as far as we know of yet, other than taking out dead bone. So when you do your surgeries, you know, err on the side of being a little more radical than conservative, because our bodies aren't what they used to be, and to generate new stuff like this is almost impossible. Tooth removal and pathogenesis of trauma from osteoradionecrosis. So if these patients are radiated, you take a tooth out, they are so susceptible to just necrosis and rampant necrosis. You have to do all your work either prior to surgery, which is the way to do it. Teeth should be removed prior to radiation. Unfortunately, in my office, I've seen several patients that seem to slip through the cracks, and they got surgery after the radionecrosis. And the only way to get them healed was in the chamber, and the chamber did heal them, thank God. But it took like 20, 30, 40 treatments. This is some of the things that you would go through on a patient who has osteomyelitis per year. You give them 35 grams of codeine. They'd have 250 grams of penicillin or tetracycline. Topical xylocaine, 4,000 cc's. Nystatin, 100 million units. Outpatient visits, 31 days. And inpatient hospitalization days, 84. Imagine the cost of osteomyelitis. Different stages of osteoradionecrosis. You have a small patch of exposed bone, not seriously involved on X-ray. How would you treat that? 30 hyperbaric exposures at 2.4 ATAs for 90 minutes, 5 days per week. Stage 2, no clinical improvement after 30 dives. Then you would do this. You'll do an alveolar sequestrectomy. After 30 dives, continue HBO past surgery until healed, maximum of 60 dives total. Stage 3, where you get dehiscence of the bone found in stage 1, pathological fractures, oral cutaneous fistulas, bone resorption to the inferior border of the mandible. Treatment, 30 dives in the chamber, intraoral resection to bleeding bone, just like you would do if you're doing a cavitation. Extraskeletal fixation, we don't have to do that. Primary closure of fistulas, continue HBO to a maximum of 60 dives or more. Reconstruction. Criteria for resolution of this would be freedom from pain, restore mandibular continuity, restore mandibular function, supply base for dentures, maintenance of intact mucosa. Do any of you work on patients who have been radiated? Have you seen any patients? Okay. So reported resolution rates from osteoporosis in the mandible based on what I just showed you, stage 1, 15%, stage 2, 14%, and stage 3, the worst, 71%, which implies surgery, antibiotics, and hyperbaric oxygen. Mandibular nerve preservation of sensation, interesting question, 75 to 100% considered normal, 6 patients, 50 to 75%, 9 patients, and 0 to 50% of normal, no patients. So there was still some preservation of mandibular nerve using these techniques and a good surgical technique. Cost of osteoradial necrosis to patients. The thing I wanted to show you here is here's patients who have not been treated with HBO, cost over $100,000. These patients have had HBO. Look at the savings here. $82,000, $35,000, $32,000. Your surgery takes out dead bone, okay? Here's a gentleman that had bladder cancer that was radiated. And this is, I think, his pubic area is right here, and his genitals are down here, his belly button's up here. And this is after HBO. It's 10 treatments. It's starting to granulate in. 20 treatments. This is a black gentleman who had a squamous cell carcinoma of the mandible. And this is his neck. He had a radical neck dissection. This all dehisced within 7 months after surgery. So they started hyperbarics. It's filling in. This is after, I think, 30 treatments. You see the granulation tissue now, the redness? And then they put a graft in several months later. This is a graft. And basically it healed up. No more cancer either. He's been cancer-free for approximately 7 to 10 years. This is a woman who had cancer of the tonsillar pillar. And she had a radical neck dissection, and basically it opened up. This represents a lack of healing here. This is after 10 treatments. You'll notice the red granulation tissue coming in here. More granulation tissue. There it is, healed up. That's after about 40 treatments. There it is, healed up. This is you're not going to believe this story. A 14-year-old white female who had a large carcinoma of the left buttocks, 14 years old. Left buttocks. Derriere, touche, permanent vertical smile. They thought it was too large to be removed surgically, and the patient was offered a hemipelvicectomy. Can you imagine that at 14 years of age? So the oncologist said, that's going to be too mutilating, let's do some chemotherapy. They did 3 courses of chemo. It failed to produce regression of a tumor. Radiation therapy was then instituted. The tumor shrank dramatically under heavy radiation. The surgeons felt they could remove it completely. Surgery was carried out successfully, but 1 month post-op, the wound dehisced, and there was no evidence of any healing. So we put her in a hyperbaric chamber. That's after 10 treatments. See, these are very special sutures that are designed to keep this wound, which had dehisced, together. They have to go under the tissue, and you have these little bolsters here.
Chris, was I clear in thinking what Bob said this morning, that you should not suture, or that it creates a problem with...
No, I'm a little upset with him. You suture, you always close it up tightly.
Right.
You know, of all places to suture, the mouth is so dirty.
But that was what he's implied. Was that what I heard him say, though? Was that what
I'm not quite sure what he meant by that. I said you did a disservice to tell these people that. I don't know why you said that. I always sew up tightly as I can. And the reason, he said, well, it means that you've cut off the oxygen supply. Well, I said there's no oxygen supply to begin with. It's a hypoxic bone. It's ischemic bone. But that tissue, if you kept a good flap, that tissue has some circulation. You want to put that over to feed the bone, and hopefully there'll be some periosteal growth into what you've just done. That feeds the tissue. But this is after 10 treatments.
Chris, what's one of these units cost?
Brand new, you can get one of these chambers for $120,000 from Seacrest. That's the best monoplace. It's a long acrylic tube that is made like a Cadillac. It's beautiful. And the patients can see out of them. We have 2 in our office, and they can watch movies, they can sleep, they can listen to music, and they can see out of them, so those patients are claustrophobic. You know, that really helps. Seacrest is the best. You can get other ones cheaper. My first chamber cost us $30,000, but it was an old Vickers. You can find these around, however, they're being snatched up here and there because people are catching on to this device, which has only been around from the 1600s. You know, medicine's a little slow to catch on to things.
Where is Seacrest? Where are they located?
California, outside L.A. You can tour their factory.
Torrance?
Yes.
Is that where Gardena?
Yes.
Torrance?
Yeah. By the way, I think they're going to go public on the stock market sometime in July. They sell thousands of chambers a year to Japan. Japan, if you call an EMS ambulance in Japan, they come with a chamber in the truck. You guys are so smart.
Chris, do you take them back up fairly slowly?
Yeah, it takes about 15 minutes. The more they get used to it, the more dives. You can take them down a little quicker and bring them up a little quicker when they get used to it and the ear gets used to it. I've been in 10 or 15 times, and I've noticed that my nails grow faster, my hair will grow faster, my beard will grow faster. I feel much better.
What about my bald spot? Just kidding.
I can't tell you certain things, but because there's no indications for it. But I mean, if you want to, I tell you what my plans are for myself is to start chelation therapy with EDTA and then get into a chamber for longevity purposes, so I can do more cavitations the rest of my life. Pardon me?
Bald spot does not change.
Bald spot. You didn't get in long enough. But look, this is what we're healing up. This is after about 40 treatments, okay? This is a year later. She went on to get married. No more signs of cancer. You know, the chemo and the surgery, you know, and the radiation did that. But now, I think one question going to come up is HBO good for cancer? Well, theoretically, cancer grows in an anaerobic environment, and HBO should be good for that. However, it does promote neovascularization, and that's how you can spread malignancies. I had a patient who had cancer of the left femur, and I did put him in that, and it seemed to aggravate his pain. I did it once, and I won't do it again. There is no literature so far that says this is good for cancer, and I think anybody that would use this might be a little risky because you have no legal grounds to stand on. Maybe in the future with adequate surgery, chemo, whatever treatments you're using, and then then hyperbarics.
I'd like to make a comment.
Let me just see if I have any more slides here, okay? That's it. Okay, questions?
The comment is that it's not generally known that, I think it's 40 million years ago, they took a piece of amber and they discovered that inside the amber was 40% oxygen. We're less than 18% now, and that's one of our basic problems. We're basically living in a hypoxic state compared to what we used to.
Right. And that's just recently, though. You know, back then it was signed, but it was pretty stable until the Industrial Revolution, supposed. And then in the last 80 years, it's come down like this, but you're right. And it's even worse in the big cities. You get down to 14% in the big cities.
No wonder you're caught.
So a simple lecture, guys, not as complicated, but any questions? Yes?
We're thinking about using silver and silver.
Bart Flick is doing that. I have, years ago, I started experimenting with platinum, and I was making little splints with electric currents trying to grow bone into sockets when I first got out of dental school and never pursued it, but I'm working on some way to take some of his material or some type of silver colloidal with some electric current to generate new bone because, number one, it would keep any bacterial growth down. It would stimulate the bone growth and a particular osteoblast.
He's been working on it at several times for several years.
Chris,
I haven't got.
I just contacted Bart, and he's not using the electrical stimulation anymore. He's putting 4 layers of the silver impregnated cloth underneath his flanks.
Okay.
He finds now that it's just as good, if not better, to a certain extent.
Okay.
They haven't got it with electrical now. They're backing off it.
Okay. Certainly, you could use some silver colloid into your surgical site. There's a company that makes silver colloid generators, and I don't have the number. They're $100, and they come with all the silver electrodes. Look like a little transistor radio. You put your little electrodes in and flip it over and stick it in a glass of water, and the current turns it on, and you generate your own silver island right there, colloidal silver. And I have patients drink it, especially cancer patients and Lyme's patients. Juan?
In your surgery, you ever used any ozone therapy or anything like that?
I used to use that a lot.
Yeah, and what kind of results do you have with that?
You know, good. It was an extra step. You know, my nurse had to get there earlier and brew it up, and I'm trying to figure out some way to do that. So I've substituted
Topical or IV or what?
topical. I have used peroxide after surgery. I think what I usually do is when I'm starting surgery, I give them some IV antibiotics. A lot of my patients can't take oral antibiotics. Their guts are so screwed up, but they can handle IVs okay, especially the ones that are really compromised. And I want to help them just for a day or two with some Cipro or something. And then I use antibiotics topically inside the wound. I use Gent and vancomycin and clindamycin and maybe some Cipro, whatever I do. And I usually muscle test or something or my little thing beforehand to find out what I need. Lately, after I've done the surgery and I flushed it with my peroxide or whatever you want to use, or water, I've been taking a 2x2 that's got a little DMSO and a little EDTA and maybe some DMPS if it checks, and I saturate that into the wound. I let that 2x2 sit there and saturate it. And in particular, I want the effects of the EDTA to give me some new vascularity, to etch some of the calcium, if you will, of the bone. And I got this idea. I was looking at some dental report showing that some periodontists, after they did some flaps and soft tissue or curettage, instead of etching the bone with an acid, they used EDTA, and they got just as good attachments of the gingiva with EDTA on the bone. So it's cheap, it's easy, it's safe. I'm doing a couple things. I'm increasing vascularity, and my flap seems to stay together longer or cleaner. You follow what I'm telling you with EDTA? And I can't tell exactly. I take a little cc of EDTA and a cc of maybe a couple drops of DMSO and some lidocaine and just let it sit in there for 5 minutes. Then I take it out and kind of just freshen up the whole socket with it. Take it out, take a look. Then I sterilize it with antibiotics, and then I sew it up. So the last step I use is the antibiotics.
Still using the aloe gel in there?
No, sometimes. I don't know how sterile it is, and there's some stuff in there I don't like.
The anachronism is they said for smoking, they're smoking, what's it, RSD or?
RSD means reflex sympathetic dystrophy, and Dieter talked about that a little bit yesterday. Now that we all know what that is, now there's a new term called complex regional pain syndrome, and there's 3 stages of that. There's a book that I recommend. It's called Chronic Pain, and it's written by Dr. Hussar, who is a neurologist in, I think, West Palm Beach, Hooschmand. He is a genius. He knows thermography. He knows RSD. And he knows the teeth, actually. And he gave a lecture, and one of my patients' sister heard about that and then finally got back to me. And he said, you can't have an RSD distally without having some type of dental problem because of the trigeminal nerve mediation and how global the effects of the trigeminal nerve are. Do you know what RSD is? Most of you have any questions what that is? Reflex sympathetic dystrophy? Yeah, right. Different etiological agents. You can have a car accident and break a leg, or slip and fall and break a limb and have surgery or something like that, and all of a sudden the sympathetics go into hyperfunction and literally shut down the circulation, shut down the nervous system, and actually shut down all the tonic things to that limb, including the bone, and the bone atrophies, and you get what's called pseudex atrophy. And essentially, if it goes on long enough, you can have a useless limb.
Would that be a form of shock then, basically?
But I've seen people, I had a patient in Santa Fe who had RSD of the arm. She couldn't use her arm. I said, how this happened to you? She said, I was working in a restaurant and somebody just nicked the back of my head with a serving tray. She said, just like this. You can cause RSDs in all your patients every day. You give them an injection. Anytime you touch something that's already hypersensitive, and you guys are going to get the worst patients. You're going to get the ones with the cavitations and the root canals, and that trigeminal is already set off, and you hit it one more time with a vasoconstrictor or something, or a filling the body doesn't like, you can risk RSDs. So, chronic pain. I think Boca Press out of Coral Gables has it. It's about $100, but it's very, very good. CRS, that's it. Yeah, CRS, thank you. CRC. CRS means can't remember shit. And that's what I have. One thing that I've been doing to avoid that, if you've done a cavitation, so you've done some traumatic work on a patient, and in my previous lectures, I use Marcaine. I just buy the big bottles of Marcaine, 0.5% plain, and I use that with just disposable syringes and needles, and that's what I use for surgery. However, they just came out with this 0.75%. And you might want to do that if you're going to be in there for a long time. And when you're done sewing up and you're ready to clean up and put a little gauze on the patient, I usually will put 1 or 2 more cc's around the surgical site with Marcaine to give them a longer post-operative anesthesia. You'll be surprised. They'll need less pain medicine afterwards. And the risk of you setting off an RSD from what you did are much, much less. Okay? You can put it around the tissue. You can put it You can put a CC into the, through your flap into the surgical site. You can reblock the inferior alveolar nerve if you want to. Just renumb it so there's more residual anesthetic, so that there's a longer period where the patient isn't aware that you've been in there. So you've told the nervous system that, hey, everything's going to be okay. And encourage your patients to take their pain medicine. Most of my patients, you can open up half their jaw and they don't have a lot of pain afterwards the next day. But encourage them to take their pain medicine. You tell them, you got to keep ahead of the pain. I don't want your brain to remember what's been here for 30 years. You have to erase the memory of the computer. And there was one Oriental physician, a researcher, that said the thalamic memory of pain is the hardest to beat. And that's part of the RSD phenomenon. That's why those are so hard to treat. Right? You know this. You're an anesthesiologist. You're taught this stuff.
What percent of marking was it?
I usually do surgery with 0.5, or I'll mix a little 0.75 with the 0.5. David?
Are you using Demerol to cut your marking levels at all?
I know what you're talking about. No. Demerol patients puke with Demerol. I don't care what you... No, I don't. No. I haven't done that yet.
Evans just did it on me. We did a whole mouth with 25 milligrams. Only about 300 milligrams, 200 milligrams of Demerol.
Locally, for nerve block?
Just
Yeah.
local, just little sub-Q injections.
Really?
Yeah, it was, I was amazed at how little it was.
Okay. I haven't tried it yet.
He did 2 cavitations on his wife with 100 milligrams per cc. He used to have the cc.
Oh, Demerol?
Cavitation, yeah.
Demerol, okay.
Right.
How long are you numb?
It stayed numb for
Hours?
a really good amount of time.
Okay.
Do you have to do it IV or you can do it just into the...
No.
Local.
Submucosally, just little injections of it. He just put little bits. He did me just a few days after he did his wife.
Same way like you would inject lidocaine or whatever, same places?
Did he nerve block you too?
No, the lidocaine would be, deeper wherever you're gonna,
Yeah.
wherever
So
you
it's
got
just
anesthetized.
little
The
submucosal.
Demerol is just like submucosally.
Okay.
And the reason for that...
Synergistic effect.
The reason for that is literature saying that there are local anesthetics break down into aniline and they cause malignancies. Lower tabs usually. Lower tab 7.5/500. If they're going to have more pain or they're a bigger person or they're a crybaby, I go 10/750. Lower tabs. Sometimes I use Percodans, and the reason I use Percodans is because there's aspirin in it. And if I think a person isn't bleeding very well, I'll encourage them to take aspirin the day of the surgery or the next day. Sometimes the next day I'll put heparin in their IV when I'm done with surgery, if they're not bleeding very well. And you can muscle test first, a little heparin. And sometimes I put patients on heparin for a week or so. I just give them a little bottle and I have them squirt themselves under the skin so they bleed. Tough stuff. There's so much that you have to think about. Yes, sir. What do I use topically? I use usually hydrogen peroxide that's diluted 50-50. I bought one of those setups from Sullivan or Patterson where you have you have your air syringe with pressurized and you have these big plastic bottles. And I buy normal saline and sterile for irrigation, and I've just poured that into that, and so I don't have to keep loading up syringes with saline. It's right there. And then I'll have a syringe of peroxide and usually a syringe. And I've been mixing a little bit of betadine with my peroxide, okay? Because betadine kills viruses, bacteria, parasites, and fungi, okay? So I'm trying to kill everything, and I'm still kind of a warrior. I like to kill things, so I have to kill bugs, and then I'll let the oxygen take over and the body heal. Just put have a 20-gauge syringe, put 5-6 cc's of peroxide, some normal saline, and a cc of betadine. And do it a couple times. If you want to put it on 2x2 and kind of irrigate it and flush things out. Sometimes you have to pick up the nerve and get underneath, clean out things there. And then I follow that up with a solution of either gentamicin, clindamycin. I put a combination gentamicin, clindamycin, and vancomycin. The vancomycin kills the staph and strep that's usually pretty resistant to things. And gent and clinda. And clinda is very good for the mouth, as you know. But it's hard on the bowels, so I just do it topically. So you can get them from Shine. They're cheap. Take a cc of each one, put a little normal saline, mix it. I mix it with a little DMSO because the DMSO will carry it into the bone. It'll carry it along the nerve sheath because you're still fighting bugs that are up that nerve sheath going to the brain. Those toxins are incredible. Sometimes, yeah. I'm trying to get a study done. I've been saving all my cavitations for a year, some little samples, and I think Doctor's dad is going to analyze them for mercury content. It's been done once in Germany, but it's been the bones around root teeth, you know. This is going to be strictly cavitations, and we're going to analyze them for mercury content. I don't doubt that that's a factor. I've never read it anywhere, but I don't doubt that's a factor. And fluoride, and I think the biggest thing is the multiple injections you get with a vasoconstrictor because you have an end arterial system here. And every time you go to the dentist, you know, from childhood on, you get that shot with a vasoconstrictor, and I think that's where you develop that sympathetic tonia with the epinephrine. You're just shutting things down. I don't think there's a place for epinephrine in dentistry today. Why would you do a crown prep on something and pump a bunch of epinephrine? You already prepped a tooth, and now you've stimulated this tooth, and you whipped it around a little bit, and you got a good chance of killing the pulp anyway. So you're going to put some epinephrine around it and shut off the circulation to the tooth to begin with. Yep. Yep. I have experimented on patients with recurrent pain afterwards or something like that. You know, as a physician, I have a tube of nitroglycerin ointment. Pull it on a Q-tip and just kind of rub it around the tooth. Or somebody's a little ischemic afterwards, you know, there's a little, doctor tooth doesn't feel right. If you want to inject them a little bit or try a little nitroglycerin paste, not too much, they'll get a headache, but it'll increase blood flow to the area. When you prep your teeth, maybe you should put a drop of DMSO on there or mix it with a little lidocaine DMSO just to quiet that down before you do your compression or put a crown or something like that. I don't care, whatever. But I think DMSO would be that you want to carry it into that area, and DMSO reduces inflammation just a little teeny bit. And that's where your muscle testing comes in, or your EAV.
The muscle test, all the teeth, if you take an amalgams out on, they all go weak. Just haven't found what's fixed on yet. You put the procaine, DMSO, DMPS, or whatever on it, you don't shrink right now.
Really? You mean after you take the tooth out?
No, I'm talking about operative.
I mean after taking the filling out? Yeah.
The amalgam, the muscle test is just weak.
You put on a mixture of something, procaine,
Okay.
but mostly with procaine and then DMSO as a carrier. And then you muscle test it, and it's strong right now.
Okay, that's a good idea. That'll quiet it down. I bet you probably don't get much post-op sensitivity, do you?
Very little.
There you go. The doctor was saying,
Sure.
the doctor was saying, okay, so you prepped a tooth, right? And you're going to put a restoration or a crown or something?
Restoration or crown, whatever.
So you mix up a solution of procaine and a little DMSO,
Yeah.
and that's it, right?
Takes all of 1 second.
And then you just apply it topically, put a little pledge on, right? Yeah?
Yeah. Muscle test it before, muscle test it after.
You do the same thing with a laser too.
Yes.
Yeah, but 1 second against how long?
What's the laser, what's the laser doing, though?
Gotta use it.
Photobioactivation.
Okay. You know, years ago when I was a dentist, you know, if I had a deep prep, I would take something called Terracortril. It was a little doxycycline with cortisone in it, and I would put a little pledge on it, and I got very little sensitivity. And I know I'm not a dentist anymore, but at least in Michigan I am, but I know that some of the post-op sensitivity is supposed to be from bacteria. I mean, I know you know that better than I do. I don't know if that's true or not. I always tend to think it's what we've done to the tooth.
Hey, Chris, I'm going to throw out one more thing since
Please.
I shot my mouth off with this.
You're doing fine.
If you put the same type of mixture into a root canal, you get the same effect.
The same mix you're talking about?
Yeah. You can go from weakness to strength.
Yeah, but how long does it last? That's the problem.
Well, you got to check it, but most of the time it's lasted. And of course, I don't know how long. I've been doing this for 10 years.
If I were doing root canals anymore, I certainly would do the peroxide and the bleach and the antibiotics like we mentioned. I would just ream the daylights out of it. And I would use some kind of paste. I wouldn't use gutta percha if I was going to do this. I couldn't do a root canal anymore, but so many of the biopsies come back with necrotic material right alongside a gutta-percha point.
Yeah, because gutta-percha is not biologically compatible.
Well, it's not only that, there's voids. You can't get a good,
Right.
you know,
can't
so
seal it.
When you section one of those teeth with gutta-percha, you see pleomorphic bacteria on stain right in that stuff. And
Really?
Growing out the tubes.
you're a pathologist, right?
That's
So you see that, okay.
I've seen that. I showed it here.
Do you see bacteria all the way through the dental tubule? It's all over, right?
I see something that looks like propagating Monilia right down the dental tubule.
The lateral ones, right?
Yeah,
Dental
they're
tubules, yeah.
Almost all lateral.
Right.
Up at the top.
Well, you must see a lot of
Around
different
the
things.
bottom, you see abnormal bacterial forms, almost invariably.
So you think different bugs colonize at different levels?
Pleomorphic form.
No, I'm not saying that at all. What
Okay.
I'm saying is you can see all kinds of stuff there.
Right. You ever see herpes virus in the cells?
Because I can't stain that. I haven't stained it for that.
Okay.
Do you see pleomorphic forms?
Yeah.
Yeah.
Around the gutta-percha and in the root canal lid or around the base, there's always something attached to the base. She looks like.
Well, that's where our pathology comes from the root canals, is the infections inside.
Yeah. And around the base.
Yeah. And Western Price said that 80 years ago. Yes, sir.
Well, just one more thing. If you ask the body, why does that change? Like if you flush a root canal with procaine, and you get to go from weakness to strength, and then you ask the body, why is it changing? The only thing we've come up with is it changes from anaerobic bacteria to aerobic bacteria. How long it lasts, I don't know.
You close it anyhow, so, I mean, the aerobic bacteria can't survive in the closed
Well,
environment.
you put in biocalyx, it's supposed to have a pH of 14, it kills everything, supposedly, and it expands. I don't know, I've tested them up to 10 years, and they're testing strong.
Really? Well,
This guy said they were all infected when you look at them.
I think they're all infected, but I think some people can handle them.
I don't
Well,
think you have to take out everyone.
Western Price said, 10% of the population can handle it. They can handle a strep, but what if they have a traumatic accident or they're overloaded? And that's what he said. At one point, they might be all infected, but some people can handle it. At what point they go beyond the edge and he broke the camel's back?
That's what I see in my practice. I always ask for a sort of question, including the family questions, and what I see that people with the happy family lives and an excellent relationship, you don't see that very often those days,
Right.
but those people can handle almost anything.
Their immune system's up.
And if you do the cavitation or you do the extraction, they
Piece of
have
cake.
no pain
Yep.
at all. I'm
Yep.
talking about zero.
Yep.
And everything heals. You don't
Part of
see-
that's the skill of the operator, too.
Well, not as good
But
as
you're right.
you are.
I think, it's amazing. You can open up a cavitation as big as your thumb, and the next day a patient comes in and they're swollen. Little, Doc, I feel wonderful today. It's like
Yeah.
the body says, God, you got that out of my mouth, or get those condominiums off my back. The same thing. It's like, wow.
I want to make another point. When you send your stuff to the laboratory for culture, you're getting standard stuff.
Yep.
And these pleomorphic forms take special treatment.
Right.
I gave this book on pleomorphic forms to a clinical
Which one?
laboratory.
Which book?
UCD. I'll remember in a minute.
Okay.
Anyway, he wasn't interested.
No, I
because
know.
He'd have to make special media, culture them for 3 or 4 weeks.
Well,
And you just can't do it.
Dr. Shackman is going to talk about that with Rosenau's works. Rosenau did this years ago, and he and I are trying to put together a lab with the appropriate culture mediums so that you have these in your offices so you can just put it right in there and then and grow it right there in your office with some kind of incubator so we can see these things and prove it.
This is the 94-year-old woman who's written it.
Dr. Matman, Stealth Pathogens, that's the
Yeah,
book.
Stealth
Yeah.
Pathogens.
She has a lab, by the way, and she does take blood samples.
Yes.
And she will find Lyme disease when you know it's there, but your blood test won't show it. I culture a lot of my stuff because you're dealing with osteomyelitis and you're a doctor and you're supposed to culture these things. Well, like I say, I think we're beyond the culture technique. It's osteonecrotic bone, but as soon as I take my little window out, I take a large bore needle and try to get down into the soft tissue where it's still kind of anaerobic and draw stuff out. And the labs think I'm crazy because I always ask for these culture, these special cultures and the thrombophilia panels, and they go, why are you doing this stuff, But anyway, they'll come back with some weird bugs, but mostly staph and strep, and there's been some Pseudomonas, there's been some E. coli, B. frag. When you get a patient with sclerosing osteomyelitis, you're going to find Eikenella corrodens.
Yeah. But you should probably culture them 3 or 4 weeks